Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended, not meant for children. And today we will be discussing about a young male patient with an anterior subcapsular cataract and what were the challenges I faced while doing the capsulorhexis. So as you can see, this anterior subcapsular plaque is right at the center and approximately 4.5 in circumference. So the main challenge was to do the capsulorhexis, as the anterior capsule is firmly adherent to the plaque. You can see the wrinkles present at the anterior capsule over the plaque. So making a nick over the plaque at the anterior capsule and trying to make a rhexis is not possible. So the aim was to make the capsulorhexis over the clear part of the lens surrounding the plaque. But the main problem is if you try to make the rhexis at the periphery, the chances are that it might run off, and we need at least 2 to 2.5 mm of a flap, which we usually follow and complete the rhexis. So now let's see how it went about. So I am making a nick, but I could not make a nick over the plaque, but I got a bit of capsule towards the periphery. But the moment I try to flip it, it tends to run out. So now I'll be using a Utrata forceps and I try to bring the rhexis back. I was able to do so, but this thick plaque is not helping me. I am unable to control the rhexis as this stiff plaque is hindering the motion of my Utrata forceps. So now I go with the micro forceps and I am able to create a rhexis till the subincisional area. But once at the subincisional area, the plaque is more towards the periphery, so I am unable to propagate the rhexis. So I nick the rhexis and try to bring the rhexis from the opposite end in the clockwise manner. So again I am able to bring the rhexis till the subincisional area, but at the moment I try to complete the rhexis, this thick plaque is preventing the movement and I am eventually pulling the zonules. Again I try, but I don't get any success from both the ends, and this rhexis is attached at the subincisional fibrous plaque. So now, instead of pulling further and damaging the zonules, I plan to cut this part with the capsulorhexis forceps, and eventually I am able to get a complete rhexis. This is the plaque. You can see the fibrous anterior capsule sticking firmly to the plaque. And now is the time to deal with this very soft nucleus. A gentle hydrodissection is being attempted to free this nucleus from the capsule, and if possible bring the nucleus up. A bit of OVD is also injected, but this nucleus refuses to come out, so by using a dialer I am able to lift up one pole of the nucleus. There is no need for the phaco probe. So such a soft nucleus can be easily removed with a 22 gauge Simcoe cannula. A bit of viscoelastic substance is injected to protect the posterior capsule, maintain the anterior chamber, and slowly we are able to remove the soft nucleus. You can see the wonderful red flow. Clean the subincisional cortex. It's better to go through the side ports. And now is the time to inject the IOL. This young patient was very cooperative. The case could be managed in topical anesthesia. A hydrophobic intraocular lens is then placed in the bag. So I have a good cover of the anterior capsule at 3 and 9 o'clock hours. So I am planning to place my haptics such that I get maximum cover of the optic by the anterior capsule for better stability. As the rhexis is relatively large, I don't intend to go behind the IOL, as the haptics might come out of the bag. Just tapping the nucleus. So the take home message is, all cataracts are not the same. The management of all the cataracts is not the same. So do what is best in your hands and what is best for the patient. I hope you like this video. Thanks for watching.